Next, I'd like to invite Professor Tawesak Tanwandee for the year reviews in hepatologies. Again, Professor Tanwandee is a world leader of the hepatologies, and currently he is the chief of the GI unit in Sirat Hospital and also the president-elect of Gastroenterology Association of Thailand. Professor Tawesak, please.
Thank you. First of all, I would like to thank Professor Viraichon and Professor Mahachai for invitation for this prestigious symposiums of the 4th ASEAN Gastro 2024. And thanks to all of the audience and scientific committees for this invitation. So for interest of time, for the highlights of hepatology, I will focus on only 2 topics that got to have some impact in your clinical practice nowadays in 2024 and 2025. The first topic got to be about the treatment of chronic hepatitis B in 2024. You might be familiar about the societal guidelines from around the globe, from the EASL, ASLD, and APASL guideline. You see that, so all of these guidelines, because of the complexities of the hepatitis B, so the cost of the drug and the side effects, so the need to have high viral load and the evidence of inflammation of fibrosis in order to be eligible for the treatment. And those days, some 10 years ago, we still talk about E positive and E negative. But nowadays, most of the drugs are NOAC, which is the polymerase inhibitor. It doesn't do anything to the E antigen because the gene of E antigen and polymerase inhibitor is far apart. So then, in the US, when they look at if they use the guideline to capture all of these VA study, so just less than 10% of either guidelines that can capture the patient with S positive that can be eligible for the treatment. But recently, when they look at the patient that in gray zone, so that's where the patient that were not eligible for the treatment, you see that up to 60% can have inflammation, fibrosis. So altogether, 73% have significant histology. And when they follow these patients for a long period of time, for 4 to 8 years, so just a few of them will become eligible for the treatment. So it's got to be very wasting of the time of the doctor and the patient to come every 6 months and see the patient and just get the result that you're fine. See you next 6 months. So then, when they look at the patient that were more severe and required the treatment, compare with the patient that less severe, not eligible for the treatment in terms of liver-related adverse events, you see that the patient with originally more severe had the less liver-related events as compared with those who left untreated. So that was the problem. And we know about HIV. Those days we started treatment when the patient have first opportunistic infection. But nowadays, we treat all the patients with HIV positive. And then we can have median overall survival of HIV infected. If he infected at the age of 20, his survival going to be up to 78, so just a few years less than normal population. So now, when we look at, this is the meta-analysis done almost 10 years ago, especially in Asian sub-study. So you see that the earlier the treatment, the more reduction in SVC development as compared with the patient with established cirrhosis. So the reduction of SVC is going to be just less than 30%. Now, this is recent study last year. So they look at the patient in gray zone and receive the treatment. So with the treatment with NOC, so these patients who did not eligible for the guideline, so you have 70% HCC reduction. That is the result why this year, March of this year, WHO has expanded the treatment criteria for hepatitis B in order to capture more than 50% of the patient with S positive. So in the past, when we used the societal guidelines, less than 10% were eligible. So now we would like to have more than 50% eligible. So this is the summary of the guidelines. So this is the original guideline with the societal guideline, but for the patient with significant fibrosis or cirrhosis, even F2, we don't need the cutoff DNA of 2,000 anymore. So any levels of DNA can be treated. And then the expansions of the treatment of hepatitis B also extend to the patient with co-infection, family histories of liver cancer or cirrhosis, the patient with comorbidity like diabetes, metabolic associated fatty liver disease, or extrahepatic manifestation with regardless of DNA and ALT. So for some countries where they cannot access to DNA, S positive plus abnormal ALT can be eligible for the treatment. So now I'll move to the next big topics of the year. It's going to be the assessment and treatments of metabolic associated fatty liver disease or metabolic associated steatotic liver disease. So this provocative guideline is raised by APASO. So the Asia Pacific is the first, the first society to look at it's not fair to have non-alcoholic fatty liver disease. That means you need to exclude everything. So you can diagnose non-alcoholic fatty liver disease in the patient with hepatitis B. You cannot diagnose non-alcoholic fatty liver disease if the patient has some significant amount of alcohol exposure. So we don't care about that. So we can have two diseases in the same person. So we just look at this guideline. The first guideline was published in 2020, and the new versions of the guideline are going to be released pretty soon later this year. So in general, the inclusions of the diagnosis is going to be the same. And the most important for all of you is the patient with type 2 diabetes. And this is a major problem where they will have progressive metabolic associated fatty liver disease. And with that guideline in 2020, that provocative guideline had raised the whole world. ESO, SLD had comes up together and tried to have the meeting in Chicago in 2022 and have their find a survey and everything. So at the end of the day, they don't follow the ASEAN guideline. One thing that changed is the metabolic associated fatty liver. The fatty liver is bullying term, is stigmata. So they just change the name of fatty liver to steatotic liver. So just use Latin words instead of the English word. So that is the change of the guideline. And then for the publication in Western journal, they comply that every publication must use their term only. So that is a restriction for us. So just to summarize, so with whether the mouthful or mouthfuls, the one thing that the movement is you can have pure metabolic associated fatty liver disease, you can have alcoholic liver disease, you can have other form of fatty liver disease, and in between, if the patient exposed to some amount of alcohol but not high for diagnosis of alcoholic-related liver disease, you can have met alcohol. So that is a combination of both diseases. Now, in terms of general practitioner and GI specialists, so there are so many guidelines. ASGA issued a guideline in 2021, ASLD issued a guideline in 2023, diabetes guideline in 2023 as well. So they use two-step criteria. So the first non-invasive, simple step criteria, and then if the patient has significant or potential of significant fibrosis, then they can be evaluated for the second step. So the first step of evaluation got to be using FIB-4. So this is simple. You just use ALT, AST, AS, and platelet count. So this can be done at any GP office. Then, if the patient has significant fibrosis or in intermediate or high risk, so greater than 1.3, then they can have the second step. And the second step, it depends on the societal guideline. AGA recommend VCTE or so-called FibroScan for evaluation. And the SLD use VCTE or use the proprietary ELF score, that is the fibrosis-specific markers for evaluation. But in terms of the outcome, you see that the two steps using FIB-4 followed by VCTE or FibroScan going to be better. So we have less referral and less false negative in terms of detection of significant fibrosis. So just to summarize, so this is the guideline that issued this year by EASL, by European Endocrine Society and also European Obesity Society. So they use the FIB-4 as the original first step, and then the second step going to be mainly by VCTE or FibroScan. And in some places where the ELF score available and FibroScan is not available, you can use ELF score and then stratify the patient according to the results of the second step of the evaluation. So if the patient have just muscle but no significant fibrosis, so just 5% weight loss got to be enough. But with significant fibrosis, so they need more to have more than 10% of weight loss, and then consider not only the diet, exercise, but also consider the drugs for the treatments of MASH or metabolic associated steatohepatitis. So for the MASH-targeted treatment, so in the patient without cirrhosis, so we can have the resmetirom. I'll come back later. And then also the treatment of the type 2 diabetes, dyslipidemia, and the treatment of obesity. You see now GLP-1RA, so this class of drugs got to become dominant in the next few years. And the first drug that has been approved by US FDA March of this year is the thyroid hormone receptor beta analogs. So resmetirom is the first drug. So this drug can have effect on the liver fat, reduce ALT, and also improve lipid. This is a pivotal phase 3 study by late Professor Stephen Harrison. He just passed away early this year. So you see that it's got to be dose-related effects on resmetirom, on the effects on improvement of fibrosis, and also the change of LDLs. So it's got to be gradient. So the US FDA recommendation nowadays, if the patient weight greater than 100 kilograms, use 100 milligrams. So if less than 100 kilograms, use 80 milligrams. So this thyroid hormone receptor beta agonist also affect on the gut microbiome as well. So this could be related to what we are having the study for today. And the criteria is non-cirrhotic, F3 and F4, F2 and F3 only. I think another study, this is from Hong Kong, is the use of the SGLT2 inhibitors to see that this can reduce the anthropometric measurement, but not change on the blood pressure. And when they use the MRI PDFF to see the reductions of liver fat in the liver. So this is another simple, and this is oral and is available in all countries in this region. And the most important got to be GLP-1 agonist. So the GLP-1 in RA got to be, you see broad effects in terms of the liver. This can reduce hepatic inflammation, steatosis, and also resolution. The bad thing for the GLP-1 RA is the price. This is a phase 2 study using semaglutide to see that the improvements of all parameters, and this come to the phase 3 study. So you see the enzyme and everything improve. So they got to have phase 3 study. Next year we're going to have the result. Another study is looking at the combination. This is the co-agonist of both GLP-1 RA and also GIPR. So this is even more effects on the livers and also on fibrosis. So just to compare, so this is the resmetirom, this is semaglutide, and this is the diazepatide. So this is co-agonist. So the co-agonist even performs better. So these coming information will change the routine practice for the patient with significant fibrosis, and there are so many studies on the way. My last topic is the movements of the treatment for systemic treatment for unresectable hepatocellular carcinoma. You are familiar with the BCLC staging. So, but the most important is the patient with intermediate to advanced stage, where previously there was no choice. So sorafenib was the gold standard for many years, but you see the overall survival, especially for Asia Pacific countries, so we have 6 months. So 6 month overall survival is okay, but it's not acceptable by most of the patients. And when you look at the breakthrough of the combination of adesivir, so you got the overall survival of almost 20 months. So this is totally changed from 6 months to almost 20 months. And with new compound, the combination with PD-1, PD-L1 antagonist, and plus anti-VEGF or CTL4, so you can have the median overall survival of almost 2 years in every compound. So now, this is the sub-study of Himalaya study just in press of the journal Hepatology this year. You see that the outcome for the Asia Pacific and the global almost the same. So we got to have about almost 2 years of median overall survival. So see, median overall survival in the next future maybe not the endpoint anymore because it's too long. So they are looking for another endpoint like progression-free survival. So in order to make the study short and then you can continue have first report, and then you can continue the study until to have overall survival. So, ladies and gentlemen, in summary, the highlights of hepatology this year is I think the thing that might be affect to your clinical practice is the expansions of hepatitis B treatment. So now it's very easy, and the cost of the drug is very cheap, the side effect is low, so let's move to the treatment. And these reductions of SCC by 70 to 80%, that sometimes in case that you cannot access to a regular surveillance program, this can be helpful. Secondly, the metabolic associated fatty liver disease, and steatotic liver disease, clarification including, so it's not non-alcoholic fatty liver disease anymore. Now you can have metabolic associated fatty liver disease plus alcohol plus hepatitis B or so forth. So the risk stratification is very important, especially in the patient for the Apostle guideline. Diabetes is the strongest predictor, followed by 2 of the 11 components of metabolic associated. That is the second risk factor. So if the patient just obese alone, that is the development of steatohepatitis is less. So the first approvals of new drug for the treatment of NASH or MASH now is resmetirom. And there are many studies to look at the receptor agonists, either alone or co-agonists on the way. Probably next year, you're going to have all of these studies published in New England Journal of Medicine. And lastly, systemic treatment for unresectable SCC. Now, there are more and more options where the overall survival, even in the patient with this late stage, especially in Asia Pacific, because all of these PD-1 or PD-L1 inhibitor, all of these has more effective in viral-associated hepatocellular carcinoma as compared with NASH. So, and this is the population in our region. So this combination can have median overall survival up to 22 months. So that's approaching 2 years. So this could be the big movement for hepatology. Thank you.